Well, hello everybody, and welcome to another episode of the European Urology Podcast. My name is Declan Murphy, urologist here in Melbourne, joined by my co-host, Joyce Baard in Amsterdam. Joyce, how are you?
Fine. The weather is very difficult in Australia, I can see.
Yeah, well, come on. Here we are in November. You really feel the difference, don't you? It's 31 degrees and sunny here today. I've got a short sleeve shirt on because it's still hot here at 10 o'clock in the evening. And what's it like in Amsterdam?
Oh, you can see my clothes. I have a turtleneck on, so it's cold. It's not freezing yet, but cold enough for me.
Well, look, we all know what it's like. It comes full circle. Being a very proud European, I remember my November days in the west of Ireland and for my many years training in the UK. So you always just wanted to get over the back of that and see springtime coming. So, I mean, we have autumn and winter here in Australia as well, but perhaps not as grim and dark as I recall in my days in Europe. So, yes, you have my sympathies, Joyce.
Thank you.
And wherever all our audience are listening around the world, we do hope you're very well. And we've lined up another great podcast highlighting the November edition of European Urology, which as ever is jam-packed, full of fantastic papers. In this podcast, if you haven't listened before, what we do is highlight two papers, which we've got coming up for you. And then Nikita Bhatt, with her regular segment, will have a quick look at a few other papers. And also coming up later in the podcast, we have one of our senior editors, Maarten Albersen, who's joining us for a chat about his role as an associate editor at European Urology. But before we get to all that, we have our two key papers this month that we want to dive into in some more detail. The first of those is from Joshua Meeks et al., looking at the role of checkpoint inhibitors, really hot topic in urothelial carcinoma. And to help in our discussion, I invited Monty Pal, GU medical oncologist extraordinaire from City of Hope in Los Angeles, and he's now the new associate editor for medical oncology. So let's cross over and join Josh and Monty for a discussion about Joshua's paper this month. So for our first paper, it's a great privilege to welcome lead author on this very nice paper published in the November edition of European Urology, focusing on the role of checkpoint inhibitors in urothelial cancer. Dr. Josh Meeks is joining us from Northwestern University in Chicago. Josh is a urologist very specialized in GU oncology. Josh, thank you very much for joining us.
Hi, Declan. Thanks for having me.
Great, and congrats on the paper. And to discuss your paper, we're joined by our associate editor for GU Medical Oncology, Dr. Samantha Pal, Monty Pal, from City of Hope in Los Angeles. Monty, thanks very much again for joining us.
Pleasure to be here. Thanks.
Great. And I know you're busy folks, so I'll cut right over to Josh to say, can you give us a quick top-line summary of this? Of course, we've put the links in the show notes so people can dive in more detail. But do you want to give us just a few of the key nuggets of your very nice review of checkpoint inhibition in urothelial cancer?
Yeah, I mean, I think that the point you made about this being a snapshot in time is perfect, because this paper probably took about a year to write. As you know, these are very thoroughly researched, but the main challenge we had is that every time we thought we had a good solid draft, there's more data and there's more advances. And so, you know, the author list of the contributing investigators are just amazing. The people that are just really the leaders in the field for this. And I think this came at a time, you know, Jim asked us to write this editorial or this review to really say, what is checkpoint therapy doing in bladder cancer? And we just had 3 1,000 patient trials in the metastatic space where we had given chemotherapy and IO. And really, I have to say, you know, overall, the results were largely negative. And, you know, at that point, the Javelin 100 trial had come out. The sequencing of chemotherapy followed by IO was a success. So there was a strategy for success, and it wasn't combination. And at the same time, we had just started to get those responses in the metastatic setting that we think we have a sense about how to sequence these therapies. But at the same time, we saw the muscle invasive trials. Many of those were near the end of accrual that, we're just starting to get those results beginning to show, like, will this be a viable strategy? We had all the adjuvant work with Checkmate 274 and Invigor 010 coming out. And then in the non-muscle invasive space, Keynote 57 was positive. It led to a new therapy in BCG unresponsive disease. So I think for the urologist, knowing, how these drugs were fitting in the metastatic setting, for the muscle invasive disease, what potential was coming, and then for the non-muscle, how potentially we'd be considering comparing them or adding them to combination therapy. So at this point, this was really a snapshot, and lo and behold, from the time that it came out online up until almost 2 weeks ago, we now have a new standard of care in bladder cancer, and the paper is already kind of out of date, and we need to do an update on it. But I think, again, for those wanting to start, this is a great primer for that.
Yeah, look, I totally agree with you. And that's why it's great to see it in a urology journal, because it does go across the whole spectrum from non-muscle invasive to very advanced metastatic. So for urologists out there listening to this is still a superb summary of what is a very, very fast moving field. And we can't dive into that whole spectrum here on the podcast. But I suppose a few of the more interesting points we'll ask Monty to speak to before, at the end, perhaps a little look into that really hot data that'll mean you'll probably be invited to update this at least every 6 months or so, Josh. But Monty, yeah, so your take on this, and I suppose bearing in mind this is mostly a urology audience, yeah, what do we need to know about checkpoint inhibitors today at the end of 2023?
Yeah, first of all, amazing job, Josh. Irrespective of all the developments that happened while you're developing the article, I think you did a really excellent job of summarizing a very, very complex and heterogeneous landscape of trials. For the practicing urologist, a couple of key points. I think that we've got to keep open the option of adjuvant therapy with checkpoint inhibitors for patients with urothelial cancer. We just heard a press release for an adjuvant trial of pembrolizumab that's probably going to be reported out in the next couple of months that I think kind of tilts the balance towards using adjuvant checkpoint inhibitors for patients with refractory non-muscle invasive disease. Keeping open that option of pembrolizumab, I think, is key as well. But Josh, honestly, you touched on a lot of this in your manuscript. I've got a question for you. We had the pleasure of participating in a study with Matt Galsky looking at the concept of delivering chemoimmunotherapy, and then in a select group of patients, really avoiding systemic therapy altogether for muscle invasive patients. Is this something that you foresee happening in the future? Is there going to be a subset of individuals where we can get away from cystectomy altogether?
I absolutely think that, organ preservation in every field in oncology, as you know, is where we've tried to go, right? And so the more drugs that we can do to get there, the better. It seems though, and again, we didn't know this in these metastatic trials that read out as we were starting this paper, that like the checkpoint seems like a great stabilization of that curve. But in some of these cancers that are super aggressive, you just don't get control of it, right? So that's where I think, thinking about the power of enfortumab, it's acting like the chemotherapy, getting control, but that stabilization curve, right? That's really where the checkpoint's coming in. So I think that's what's so exciting about this field, is in the future, what are we going to be doing and how are we going to be treating patients? So I'm really excited about that concept, Monty. I think, getting to that point of, bladder preservation, is really going to be the next wave.
Yeah, absolutely. Absolutely. I've been really fascinated to hear about some of these efforts to deliver intravesical therapy. And one thing in particular that's intrigued me, I just ran into Saeed Hussein at the airport, my way back from ESMO, and he was chatting with me about intravesical delivery of checkpoint inhibitors, which kind of blew my mind, seeing that for ERDA and some of the FGFR-directed therapies, which kind of makes sense. But I mean, is that the future? Do you think that intravesical therapy will basically be a tool that we can use to deliver virtually any treatment?
Well, it's an interesting question. We had that first phase 1 study that was in European Urology. I think what I got from that study, again, for putting pembrolizumab in the bladder, was that it had surprisingly large amount of immune side effects, right? So we had side effects of, diarrhea, we had myasthenia gravis, which are terrible side effects for patients, but at least suggest that you can engage the immune system from bladder delivery. I think it needs to be studied, though. I think companies that do a great job studying therapies need to take up that approach. And that's really what needs to happen rather than, investigator initiated studies. But I think it's a great opportunity. Again, I worry about the systemic therapy options for people who have metastatic disease, because that's ultimately where we lose this battle.
Yeah, absolutely. I'm also just sort of thinking about, the status of bladder cancer after we expose patients so early on to immunotherapy. Right. So once the patient hits me in the metastatic disease clinic, it's probably going to be a different protoplasm than what we've encountered in years past, right? I mean, I just wonder if somebody's gotten, intravesical checkpoint inhibitor, they've gotten adjuvant therapy. What am I going to treat them with? I think that's one of the sort of lingering dilemmas. I wonder if you have any thoughts on how the disease is going to evolve.
I mean, I totally agree with you. And our language has changed, right? So I was just talking to a patient that was node positive, bulky disease at cystectomy. And I'm thinking, are we talking about nivolumab for this patient? Or is that a EV Pembro patient? Because I don't know what's the best option for them right after surgery. And to your point, I don't know if someone's on nivolumab and they progress, if you challenge them with, the EV Pembro. I think that's a major question that we need to figure out, is when people have seen this class of drugs before, but you introduce another drug in combination, are they just as effective? I think there probably will be some data about that, but again, it's what we put together with it that's going to be important. So a lot of exciting things to look at coming up.
Yeah, no, totally. And the last question I have for you here, really pertains to, something I know you've done a lot of work in, which is subtyping of bladder cancer. I think that in kidney cancer, we're trying to take a stab at it. In bladder cancer, some subtypes are well defined, but the clinical application of that right now is a bit dubious. What's the way forward for us to start using these subtypes that we've invested so much energy in to actually treat patients?
Well, I think we're going to test that, right? So that's the goal of the subtype trial, that we're doing with SWOG, to see if different subtypes, for example, more basal tumors, will be more responsive to checkpoint therapy, for example, when you add an anti-TIGIT as well. But I think if you think back to how these drugs work, right? So for a PD-1, PD-L1, they work locally on the tumor. So that you have to have immune cells present for many of these tumors for these drugs to work. And if you don't have immune cells, it's very hard to get a response. Maybe that's where the chemo works, is to kind of break up those tumors to allow the immune cells to come in. But I think understanding that basic biology is really going to be a critical part to this. So subtyping, again, there seems to be differences, and I think they're going to be tested, us, and as well as, Jim Cotto's got another trial just as well to test that question.
Thanks very much, Josh and Monty. And before we finish, it's hard not to talk about the sensational data from EV302 that Tom Powell's read out in the presidential at ESMO. And I know you highlight that trial was coming, and of course the paper is not out yet. But Josh, can I ask you for your reaction to this enormous paper? I don't know where you at ESMO, but it was unbelievable in the auditorium, and people were clapping in the middle of the presentation as soon as they saw the OS curves, and then there's like a standing ovation at the end. It was like quite extraordinary.
I mean, it's an amazing time to be someone taking care of patients with bladder cancer. Yeah. I mean, it's so nice to be able to tell patients, this is what we would have done 2 weeks ago, and now that's not the case. Now we have, a very different standard of care. So the data is amazing. I think it's going to be how we treat people. I can't wait to see it, see the data in the manuscript and see how it affects things. But again, I think there's still going to be questions of there are going to be non-responders. And so how do we address them? But that data is just absolutely amazing. And again, the Pembro clearly adds to the EV alone. I think that mechanism of how it's doing that needs to be figured out a little bit. But again, the data itself and the treatments for the patients it's a new day for bladder cancer.
I totally agree with you. And it's really not that many years ago. I'm sure you'll remember it as a younger urologist when there was just nothing in bladder cancer. It was like the most depressing things, muscle-invasive bladder cancer with nothing for 40, 50 years and really bad outcomes. So I think for patients out there, it is exciting times. And I'm excited by it because I think, if you see some progress like this, you attract in really good investigators. You attract in people like yourself and Monty and the other people who are leading these trials, because now they can see this is an area where we can really improve outcomes for patients. So it's not a dead end anymore. We can really make a difference. So, and that's why your article was selected expected. We're really excited to see this, but we will very much look forward to having this updated quite regularly in the coming years. So Josh and Monty, thanks very much for joining us again, and congratulations, Josh.
Great discussion, Declan. Really enjoyed the discussion with our two guests. So definitely worth to read, to go back to the journal and read this paper.
Yeah.
So what else do we have for today?
Absolutely. In these discussions, we can't go into great detail. That's the whole point. Is that the whole paper is there in European Urology, and we've linked to it in the show notes. But I agree with you. It was a very lively discussion. In these podcast formats, it's fun. We can invite on one of the authors, but it's great to have somebody like Monty to come on and have a good, robust discussion about what this really means as well. So
yes, great.
Moving on to something totally different, of course, our second paper this month is a totally different topic, a really interesting issue, talking about continence and mental health in adolescence. And you led that discussion with your authors, who I'll let you introduce as we cross over there. Thank you, Joyce.
So for this next section, we go to a totally different topic. We go from checkpoint inhibitors in urothelial carcinoma to continence in teenagers. So I'm very happy to introduce our second two guests. We have Professor Carol Joynson, Professor of Developmental Psychology at Bristol Medical School, Bristol University. She's the senior author of the Platinum Priority article published in the November edition, Continence Problems and Mental Health in Adolescents from a UK cohort. So welcome, Carol.
Thank you very much. It's good to be here.
Perfect. And then we have a second guest. That's Professor Dr. Anne-Francoise Spinois. She's a pediatric and reconstructive urologist. She's from the University Hospital in Ghent. And actually, she is also the first female professor of Belgium. So we're very happy to have you here in the podcast to discuss the article of Carol together. So welcome, Françoise.
Thank you, Joy. So, and it's a real pleasure to be here to discuss this article.
Perfect. So, Carol, I think it's a really impressive publication. You included over 7,000 teenagers prospectively in a cohort. So congratulations on this really nice publication.
Thank you.
And before we go further with the discussion, I would like you to just give a brief summary of your study. What was the intent to start with the study, and what would you say are the key findings of your publication?
Thank you. So the reason for us conducting this study is because we already know that young people with continence problems experience a range of unique stressors in their daily lives. But what we don't know is whether these stressors have a subsequent impact on their mental health. So we set out to examine if continence problems in mid-adolescence, so around the age of 14, are associated with an increased risk of subsequent mental health problems in early adulthood, so around the age of 18. And we conducted a prospective cohort study using data from a large community-based cohort based in Bristol. It's known as the Avon Longitudinal Study of Parents and Children. It's a really famous birth cohort study. We looked at a range of self-reported continence problems at age 14, things like daytime wetting, bedwetting, fecal incontinence, and other lower urinary tract symptoms such as urgency and frequency and voiding postponement. And we looked at a range of mental health problems that commonly emerged during adolescence, and these include things like depression, anxiety, self-harm, and disordered eating behaviours. And so our key findings were that adolescents who experienced continence problems at age 14 were more likely to have a range of common mental health problems at age 18. And these included mostly anxiety and depression and depressive symptoms, we found that daytime wetting and voiding postponement were associated with most mental health problems, and that all of the types of incontinence and lower urinary tract symptoms were associated with increased anxiety. And importantly, we took into account other factors, so confounding factors, such as gender, socioeconomic status, developmental delay, and previous emotional and behaviour problems. So yeah, that's hopefully just a brief summary of what we did.
This is an amazing amount of work, Carol. It's really amazing to see these data. And I think what's important here, as you mentioned, is this is a huge amount of prospective data. Those children have been included from birth on and have been followed up until 14, where they received this first questionnaire, and then 18, where this 18 years assessment of their mental health. So I have a first kind of question, the question that always come back, maybe the question of the chicken and the eggs. What is the source of what? So basically at 14, those children were asked about continence, and those who had problems were asked again at 18 about mental problems. So there's an association, but is it the incontinence maybe causing mental problems, or could it be the other way around?
That is a very, very good question. And in fact, that's the topic of a programme of research that I have at the moment that's funded by the Medical Research Council in the UK. So specifically what we're looking at is whether there are bidirectional relationships between mental health and incontinence. And some of our previous research has found evidence that children with emotional and behaviour problems and exposure to stress in earlier childhood have an increased risk of continence problems later on. So these children are less likely to have achieved continence by the time they go to primary school, and also to experience persistent incontinence into later childhood. So I do think there is evidence for an association in the opposite direction, and we're currently examining that. In this paper, it's important to point out that we took into account earlier levels of emotional and behaviour problems around age 11. So by adjusting for these earlier psychological issues, we are possibly looking at the effect of the continence issues on the later mental health problems, but we cannot fully rule out that the association may be in the opposite direction. I do believe there are bidirectional relationships.
This is really interesting. But next to that, maybe I missed it, but I said, as far as I could find, there is no data about possible treatment of this incontinence, right? We don't know if they had any treatment or if there was anything undertaken to treat it, right? So we don't know the possible influence of it.
Yes, and that's a limitation that we have included in our discussion of this paper.
Mm-hmm.
So because this is a large cohort study, it's based on questionnaires, many of them given to parents, and then as the children got older, they completed their own self-report questionnaires. There's certain things that we don't know in a community-based cohort, and one of these things is about the treatment, and that's something that further studies would need to look at, the impact of treatment on later mental health issues.
This is amazing indeed. Because even if we don't know the effect of treatment, of possibly we know there's an association. So I think even in this month of November, where the focus is set on male cancer, well, don't forget that incontinence also is really important and might be associated with health, mental health problems. So I think it's really important to raise awareness about that and have prospective studies about it, right?
Oh, definitely. And I mean, this is the first study that we're aware of that has looked at the impact of continence problems in young people. And there are some studies in adults and mostly in women, fewer in men, showing that there are also impacts of incontinence on mental health.
Further, that this cohort is still followed up, so there is a possibility of having more questionnaires about it upcoming in the future. May we expect more data about it?
Yes, so the young people in this cohort are now in their 30s. So the Avon longitudinal study started in 91 to 92 and is ongoing. So there are more questionnaires currently being completed on mental health. We have further incontinence data when the young people were around age 19. So there is a possibility of looking at whether these later symptoms at age 19, following them up to see if these have an impact on mental health in adulthood.
And is there any possibility in the future to look at the possible treatment in the follow-up of these patients, or is it something that is not possible until now?
There is a possibility of doing that because this cohort has linked data to health records now, which is being used more and more frequently. So there is a possibility, and it's something that I am actually currently looking into doing to see whether there is any impact of the treatments. The issue is in a community-based cohort that a lot of the children don't reach the threshold of having clinical levels of continence problems. So we're looking at continence problems across the whole spectrum within the community rather than those that just reach that threshold of clinical diagnosis. So if we were to use the linked health data, we may be looking at very, very small numbers of participants who actually have accessed healthcare for their continence issues.
But that's even if those populations are really small, this is unique data. I mean, there is nobody else who has such a prospective cohort on the long run. So even with small numbers, I think it would be really interesting and really groundbreaking, possibly.
Yes, I agree. Yeah, it's something that I'm very excited about being able to do.
Will you be eventually thinking about using standardized questionnaire about quality of life, like the pediatric questionnaires in the future for those for LUTS quality of life for those patients to make it easier to follow up?
So we do have some questionnaires on well-being. So that's something that I'm also going to be looking at. Quality of life specific to continence issues is something that this cohort study hasn't asked. And it's a cohort study that is obviously not specifically focused on continence problems, but a range of health outcomes. So yeah, we have to rely on the questionnaires that are included in the battery of questionnaires for the cohort. But yeah, we can certainly look at well-being as an outcome variable.
Okay. Another question that triggers my mind is are all self-reported questionnaires. They all report their symptoms. Is there a possibility that, given that incontinence is still a taboo in some countries and in some regions, that incontinence might even be underreported in this population?
So that's something that I've thought about quite a bit. The things that are reassuring to me are that the young people who are part of this cohort study have been part of it since birth. So they've grown up being participants in the Avon longitudinal study. And there's a huge degree of trust between the participants and the people who organise the study. The other thing that reassures me is that when I look at the prevalence of continence problems in this cohort compared with other population-based studies, it's similar. So I would say that there's always the possibility of underreporting because of the perceived stigma. But I would say because of this unique relationship that the participants have built up, their reports will probably be trustworthy.
Okay, that's really interesting. I would like to remind also for all possible listeners that this cohort from England is a population cohort from the southwest of England, so might be really representative from many readers or listeners from European urology. It really represents Europe like it is, with no minorities. It's quite representative, and so I think we have here really quite a good idea with this unique cohort that basically we have to look more into incontinence problems if we want to possibly avoid mental health problems in adolescents and young adults. So that might be really a population-based thing that we need to focus on in the coming years to avoid mental health problems on a larger scale, right?
Yeah, I absolutely agree. And it's quite timely that you say that, because today we've just published a policy report which talks about these findings, the increased risk of mental health problems, but also thinking about what we can do to prevent continence problems in young people through early intervention and identification of bladder and bowel issues, but also to support children and young people who have a continence issue to be able to manage their symptoms and hopefully reduce the risk of them going on to develop mental health issues.
Okay, this is even more interesting. This kind of thing, I think, wraps up all my questions, because you talk about education and making people aware about incontinence and health problems. That's where this podcast starts, with making you also urologists aware of this problem and that we need to treat it and make it discutable, make it possible to discuss it at the consultation. There starts it's all, I think. Thank you very much for this really, really, really outstanding work. And I recommend all people who are listening to this to read this marvelous manuscript. Thank you very much.
Thank you very much.
Thank you, Françoise. Thank you, Carol. I think you really nicely wrapped things up and make a good conclusion. It's really an impressive study. Congratulations again. Thank you for joining our podcast, and thank you for your time.
Well, thanks very much, Joyce. That was an absolutely fantastic piece. I really enjoyed that. As somebody who specializes full-time in GU oncology, it's not often I get to hear a discussion on a topic very much outside my own personal interest, and I really enjoyed that. And congratulations to Carol Joynson and her team for that fantastic bit of work. But now we're joined, as ever, again by Dr Nikita Bhatt, joining us from the UK to chat about what else is going on in the journal. Nikita, thanks very much again for joining us.
Thank you for having me. It's a great issue again this month. I have picked 3 articles for us to discuss, as usual. I'll start with the first one. So the first one is the Surgery in Motion article on robot-assisted radical cystectomy with orthotopic neobladder reconstruction. And they discuss essentially techniques, functional outcomes in males in a multi-center study over 700 patients at 12-month follow-up. And this article is by the scientific working group of the robotic urology section of the EAU. And as we're all discussing robotic reconstruction more and more, and it's taking center stage, I thought this one is definitely worth a mention and a read.
Yeah, this is a really nice article. It's, I think, the largest series describing the functional outcomes of patients treated by robotic-assisted radical cystectomy. And I think especially for patients, it's important because you can do a beautiful surgery with good oncological outcomes, but if your patient is leaking afterwards, this is what will impact quality of life of our patients. So also for counseling of the patients, what to expect after surgery, I think this is really valuable information. So definitely worth to read.
Yeah, for sure. And because it's in Surgery in Motion, of course, there's a really nice video going along with it. We'll include it in the show notes. Yeah. And that reminds me, actually, of course, with the new editorial board that's just coming in at European Urology, we have 2 new Surgery in Motion editors as well, Nina and Ruben, and we're inviting them on in the next couple of months to talk to us about the Surgery in Motion section. But yeah, thanks very much, Nikita, for highlighting that. What else have you got?
Well, I've got something really interesting next, and it's keeping with the robotic theme. This is a research letter on robotic bladder autotransplantation in a heart-beating but brain-dead human research donor. It's been written and performed by Indibil Gills Group from USC in the US. This is, of course, first of a kind report on something like this. It's a preclinical step before first in a human patient. And if this is successful, then they could offer potentially a bowel-free, more normal bladder substitute in selected patients with bladder failure. However, obviously things to consider are immunosuppression when you're transplanting bladders, especially bladder cancer and people with chemotherapy, etc. But definitely an interesting read. Yeah.
Very interesting. And I don't know, Declan, what do you think? Will this be the future for patients? How would you position this?
It was one of those ones, you know, you had to read the title a second time and a third time to think, hold on, what exactly did they do?
What am I reading?
Robotic bladder, okay. Auto-transplantation in a heart-beating but brain-dead human research donor. And so you have to try and figure out what they've done. And look, coming from Indy Gill's group at USC, we're not surprised to see, you know, extremely ambitious innovation. And, you know, I think it is exciting. That's why I got into a big journal like European Urology to see some of this ambition to perform these types of procedures that might improve quality of life for patients. But clearly we're a long way from that. But I still think it's a really interesting technical achievement to have done that. And although that paper wasn't selected as one of our podcast priorities for this month, we are planning to invite some of Indy's team onto GUcast, our other sister podcast, to talk about this in a bit more detail. But yeah, well worth highlighting, Nikita, for something a bit out there, a bit left field, I think, at this time.
Yeah, absolutely.
Well, the third and the last one is a platinum opinion, and this is looking at differing recommendations on prostate biopsy approach to minimize infections. The authors compared the EAU guidelines with the AUA guidelines. And essentially the gist of it is the EAU guidelines recommend prostate biopsy via the transperineal approach because of the lower readmission rate for infection and sepsis, while AUA recommend either approach, transperineal or transrectal. And the authors are Hu et al. From New York. They explore the differences in the evidence and the resulting recommendations, which are useful, I think, for any practicing urologist to read and understand.
This is very interesting, right? You have two guidelines, two important major guidelines with different recommendations published in the same year based on the same existing literature. on one hand, the AUA saying there's an indication, there's a need for randomized controlled trials, and the other one, well, questioning a bit the clinical equipoise to conduct randomized controlled trials. So I think it's indeed very interesting to read this, and also for us clinicians to, when we read guidelines and we read recommendations, also sometimes to go back to the initial studies where recommendations are based on. So I think this is really an interesting read. Yeah.
Yeah, I agree, Joyce. But isn't it funny how, you know, a group of expert authors will have a look at the exact same data, because that's what looking at the evidence is, and yet you can have quite different guidelines. And it's not the first time we've seen that, of course. And what is the explanation? And I think a lot of the time these society or country specific guidelines like the AUA have to take into account what's actually achievable or possible. And so if they came out and said, we believe transperineal is the preferred approach due to low infections, etc., the problem is it's just not possible to do that across the scale in the US, because they have a lot of resource constraints to do that, or have had, certainly doing it under general anesthetic. And I think that's changing as the more local anesthetic approaches are available. But I'm sure still like 95% of biopsies are probably done transrectal in the US, whereas in Australia, 95% are done transperineal, and in many parts of the UK. So that I think explains why there will be different interpretations depending on what's actually available. I think guideline bodies have to be a little bit pragmatic sometimes in how they punch out messages about that. It's quite similar when we look at the guidelines on the role of MRI as part of early detection for prostate cancer, where the EAU are very enthusiastic, AUA maybe a little less so, NCCN less so, because they have just resource constraints. It's not as easy to get MR pre-biopsy or MR to avoid a biopsy even. So but really, really nice work from Jim Hu and team to highlight that and show it up. So nice work, Nikita.
Thanks very much for having me.
Yeah, and now Joyce, we've really enjoyed this segment. This is our third monthly episode of the podcast, and we've had really, really good feedback from Nikita's segment, but unfortunately she's leaving us for a few months.
Yeah, that's right. I've got some personal news. So I'm pregnant and due soon. So we'll be busy a few months for me. Unfortunately, we'll have to take a break from the podcast, but I've had a lot of fun doing this segment, and hope to continue it in the future.
Absolutely, for sure. And pregnant with twins, Joyce. Did you hear that news?
Yes. Impressive.
Don't do anything easy.
Exactly right. Well, look, it's very good of you to give them your time while these little babies are growing healthily, and we wish you all the very best for a safe arrival in the next few months, and indeed to welcoming you back on the podcast next year. But Joyce, because the segment has proved very popular with Nikita, we had an idea that we might reach out to our audience out there to see, are there listeners, especially younger listeners like trainees or junior faculty, who might be interested in covering Nikita's segment. We're pretty keen to continue that, Joyce, aren't we?
Yes, would be very nice, and I think you will give it some further attention also on the socials, how people could apply for being a host in our show.
Yeah, absolutely. We'll put some contact details in these show notes, and we will push out some messages through European Urology social channels. So if you're interested, just get in touch, and hopefully over the next few months we'll have a variety of people who might come on and try and fill Nikita's boots while she tends to this much more important personal activity she's got coming in the next few months. So yeah, but we look forward to welcoming you back next year, Nikita, and we wish you all the best in the meantime.
Thank you so much.
Keep us posted.
Will do. Thanks for having me again.
No problem. Thank you. Well, now for our Meet the Editor segment this month, it gives me great pleasure to welcome old friend Dr Maarten Albersen, urologist at the University of Leuven, who is an associate editor actually for quite a while at European Urology. He's not just part of the new cohort who have joined, and he's joining myself and Joyce for a bit of a chat about his role as an associate editor and a bit about, life in general. Maarten, welcome, and thank you for joining European Urology Podcast.
Thank you very much for the invitation. to both of you, and congratulations on the first episodes, which were really nice to listen to.
Yeah, thank you very much, Maarten. And yeah, so look, I have a lot of personal connections going back to your institution, to Leuven for many years. Obviously, for people like myself and Joyce, there are certain big institutions in Europe that have dominated a lot of our impression of urology in Europe over the years, and Leuven's certainly been one of them. I remember your old boss there, Hein van Poppel, when he travelled down here to Melbourne. It must be about 10 or 12 years ago, and he took a look around the place and said, "Oh, we should have more affiliation. You know, maybe we should send some fellows down to Peter Mac to train down here." And I remember that was over a beer late one night, and then I said, "Oh yeah, that'd be great, because I'm European, and we this is a great city, Melbourne to have." And next thing, like about 2 months later, he emails me to say, "This is the name of the first fellow who will be coming in a few months' time, blah 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 blah." And then that led to a really strong connection to your institution. We've trained many of your fellows and staff over the years. So yeah, I really value the connection to Leuven.
Yeah, we do too. I think there's a lot of how should we say, Australo-Belgians walking around here in our little country. Have been trained by you and your peers, and they all seem to have had a very good time there.
Yeah,
absolutely.
Look, it's great, and I've enjoyed visiting you, of course, as well. So look, before we talk about your role as an editor and maybe some tips and stuff for our audience who might be scarred already from having submitted to big journals like European Urology and got rejected. I certainly bear those scars myself. We wanted to just ask you about your clinical interests or your research interests. So tell us a little bit about that, and then we'll ask Joyce to run through a few questions about European Urology as an editor.
Yeah, so I work, as you said, in Leuven, and we're actually quite small. We're quite a small team, and here I take care of the andrology. I take care of penile, testicular cancer, and renal cancer, and I do also still the open cases, as you are very much a robotic surgeon. I'm still sticking to the open that Hein taught us, but I'm also doing some robotic cases, but that's my caseload, and that overlaps largely with my research, which is mainly oriented at penile cancer at the moment.
So great. So you work as a senior editor for the European Urology. Can you walk us through a bit? So how does the whole process work? So if I send you a manuscript and it's in your area of expertise, how does it work? What do you do as an editor?
Yeah, so it is quite a lot of work, actually, because a lot of manuscripts are submitted to the journal on an annual basis, and we're not such a large team. So as each associate editors gets, I think it's about between 7 and 10 papers a week that we get to handle. So you really have to log on every day, have a look on what's new. So Alberto assigns each paper to a certain associate editor. Title is obviously the first thing that catches your eye, and based on the title you already get a good idea on where this is going, at least if the authors have constructed a title that's good and representative for the research they did. And then obviously you look for the stuff that is not going to make it in any case, and this takes some experience. In the beginning you tend to send out a lot for review, and as you get more experience as an editor, you know what's not going to make it, and you don't want to burn reviewers unnecessarily. So there's quite a lot that's straight rejected. Actually, the majority of papers that we get in are straight rejected, and those
what type
are the ones.
Sorry, what type of manuscripts are that? So if you see a title, based on that, will you reject something, or is it
no,
more than that?
Not.
And what is an instant no for you?
No, you'll get an idea based on the title, but you obviously need to go through the abstract in detail, and if any doubts remain, you go through the manuscript in detail as well. But this is the first thing I do if I look at my inbox, are the straight rejects, because there we dedicate ourselves to give the authors some feedback on why the paper was not suitable for European urology. So you have to take some time to summarize the findings, the methodology, and also the drawbacks of the paper, which made you decide it's not going to be for European urology at this form, in this current form, at this current time. Definite straight rejects are, I would like to abstain from saying that a certain article type would be a definite straight reject, because if I say retrospective single center series with only univariate analysis are probably going to be straight reject, yes, they are. On the other hand, there's some unicorns that may have some very valuable information. So you have to go through it in detail. So systematic reviews of poor quality retrospective studies, case reports, predictive models that predict non-clinically relevant outcomes, poorly written manuscripts in general, highly niche topics, which we know are only of interest of a very, very small group of urologists. Those are likely to get a straight reject. Although we have to be careful not to throw out the babies with the bathwater, as we say.
Yeah.
And so we have to pick up the unicorns there as well.
Martin, I remember...
And do you have manuscripts where you really think, oh, wow, if you see this, I'm instantly happy, and this will be a yes? What type of articles are that?
Well, in my own research background is andrology, and I have to be honest, since funding is out of andrology, the quality of research has dropped, because that's always the case. Like, you know, oncology has major funding, their research quality is very high. This is why the majority of the articles in the journal are oncology, obviously. But for example, in andrology, you don't see many RCTs. So if I see an andrology RCT, I will not say I get aroused, obviously, but I get excited and say, wow, they managed to do this. They managed to do an RCT. For example, an RCT was published in European Urology that I handled a couple years ago on microTZ, and that excites me. That doesn't happen very often in our field. Penile cancer, for example, no RCTs running. Testicular cancer is a bit different, obviously. There we have good quality studies that come into the journal.
Yeah, I recall, Martin, the words of Francesco Montorsi, previous editor. I remember when I was a younger trainee, and he was asked that same question in a forum about what do you look for as an editor, and he said, what I want to see is prospective. If I see the word prospective in the methodology, a prospective trial of any sort, especially if it's a prospective randomized trial, then immediately you have my attention. And he then drew the differentiator to say, I don't mean that in your institution, you know, you have a prospective database and therefore you went and pulled out some prospective data on 500, 800 consecutive patients. I mean, you sat down and you developed a protocol, you had a research question, you had some stats, you got some ethics approval, you started a trial and you finished it. That's what prospective means. And I remember thinking, right, so therefore that rubbish that I submitted that just got straight rejected from European that I thought was great, it was like 800 patients from 4 different institutions, but like lots of selection bias got straight rejected. And if he made the point when I asked him that, he said, well, if you had a 50-person prospective trial where you had a research question, you had a hypothesis, you had some statistics, and a start point and end point and so on, in clearly stated inclusion exclusion criteria before the trial starts, then that's much higher quality, 50 versus 800. So is that still true when you look at something? Are you really looking at, because that's the way I look at papers as well as a handler, I look at where does it say prospective, and you have to watch for the shady urology trainee like I was in my day, who is trying to dress something up as prospective, but in actual fact, when you dive into it, or this is actually a retrospective review of prospectively gathered data.
Yeah, that happens a lot. Obviously, databases can be prospectively collected and maintained, but the research question then is retrospective if it's not defined when you set up your database. And so those databases are not made for answering these research questions. We see that a lot. Also, database milking happens a lot, and those are the articles that you don't want in a journal as European Urology. Data needs to be impactful, it needs to be novel, it needs to be generated by solid methodology, which are the things that you mentioned, Declan. So defined primary outcome, defined secondary outcome, defined time frame, defined research question and hypotheses. And preferentially, they should impact clinical practice in the immediate or in the long term. And that's not going to be the case for all prospective papers either. So.
And another question we often get asked, Maarten, by younger trainees as well is, what tips do you have? I suppose we could ask you it in two ways. Tips for people submitting to the journal. I mean, everything you've just said is really helpful for that. But I suppose tips in general for young people wanting to get into urology, or how to develop areas of interest, or how to plot your career, develop fellowships, because you've done quite a lot of fellowships. I remember you've been a number of different overseas fellowships in your training. Any tips for our audience about how to plot out a successful career and a successful submission?
Successful career, tip number one, and absolutely the most important one, is I think you're the sole responsible for your own training. So don't be passive, be active in your training, read, prepare your cases, go to conferences. If you have the feeling that you reach the limits of the institution where you're in, for example, you don't get to do surgery, or you don't learn as much as you would have anticipated, then look further, go abroad. Get a mentor is a good tip, I think, not only for educational purposes and learning, but also for advancing you in various aspects of the career. Like, if people in top positions know you, that helps you advancing your career. Pick a topic that passionates you, and be realistic and pragmatic, because maybe you end up in a field where it's very difficult to do good research because there is no funding, for example. Then also realize that the topic that you choose may not be for you for your whole career, and dare to make a switch. Myself, I made a switch from mostly andrology to oncology, and that's mostly based on the funding that we could obtain. Make choices is a very important one. So don't say yes to everything, because you will overcommit and you will not give the best of yourself if you have too many commitments. So ask yourself, is this lecture good for the audience, but it is also good for me to give? Is this textbook chapter really worthwhile? Is anybody going to read it? Or is it just a way for the publisher to make money on my back, right? Does it help me move forward? Also select what you do. I mean, we talked about prospective, retrospective research, but to be fair, most of us start with retrospective research because you have to start somewhere. So you use a database of your institution or mentor. And while it may not get published in the highest impact journal, it helps you get familiar with statistics and so forth. But don't stick to that, right? Try to come up with a plan for your career, with a research plan for your career. Maybe it's better to early on start applying for grants than to keep doing retrospective database work and get as many PubMed records as possible. Maybe it's better to get few PubMed records, but very qualitative ones. And largely, a very important one, your career is not your life, right? So be sure that, yes, of course, it's fulfilling to operate patients. Is it a big part of your life? Yes, it's a big part of your life. But you don't want to come home and be alone or work every weekend or every evening. So make sure that you have distraction from your work. It makes you more productive at your work as well. Make sure you have plenty of opportunity to get rid of your stress of operating, of deadlines and demanding patients. Make sure that when you retire, don't face a big black hole. So live a little outside of your urology career is also a very important tip, I think.
That's fantastic, Maarten. I was making notes of all of those as you were reading them out. I totally agree. Some great advice there for like the professional side of your career, but also the personal side. And I remember at the start of COVID, when I just was approaching my 50th birthday, and I was asked to deliver a talk about avoiding obsolescence as a cancer surgeon. So I did a virtual talk. It's on YouTube still, and I had my top 10 tips for sort of staying relevant. And a lot of it was stuff like you just said. It really resonated with me. Including the change focus thing, because if you went and did a fellowship in the US back in the day, and it was this hot technique that everyone was interested in, but chances are, of course, 10 years later the field has moved on, and if you never moved on, if you didn't have a broader view on what's relevant for your disease area, whether that's stone disease or on andrology, oncology, Yeah, you're not going to be doing the best job for your patients. And guess what? Nowadays, the patients will have moved on as well. You're going to have a very lonely second half of your career. So yeah, I totally believe this sort of lifelong learning is a really essential part of remaining relevant and not becoming obsolescent. But also, I think, enjoying your career, making sure that you're still enjoying the reason you came into urology. Make sure you're still enjoying that 15 years later, 30 years later, and so on.
Absolutely. Absolutely. And also accept that it may not always be happy, joy. You could have some dips for a couple of months, but if you enjoy your work, you'll always make it through. I firmly believe that.
And in finishing up, just back to the journal, because it's quite a burden actually being involved in peer review, whether you're at the senior editorial level like you are, or just somebody who is on a couple of board of reviewers, because this is largely unfunded work unless you are in the senior ranks. So it's quite a commitment. So and with so many journals out there now, and even like us, European Urology, spinning off a few journals, there's an increasing burden of work on a relatively small pool of reviewers. And your comment earlier that, as you've become more experienced, you're very conscious that, well, I'm not going to send out this paper unless I'm really confident it's going to, it's got a high chance of getting there. Partly because, that reviewer might also be getting reviews from 4 other journals, and he or she might have a particular niche interest. That's even worse then, because you're the only 1 or 2 who might actually return the reviews. But I say to my trainees that, look, there are important reasons why it's good to get involved in peer review. For me, one of the first ones, and this is one of the reasons I enjoyed starting to do peer review a few years ago, was if you're with a journal like European Urology, BJUI, JUROL, these bigger journals, the papers that are getting sent out for review are generally very good papers, even if they don't get finally accepted in that journal. So so therefore it's interesting to read these papers because they will get published somewhere. So you're reading a really up-to-date review, from good authors, and particularly the discussion. And I often found myself, when I was reviewing a paper, making a few notes from the discussion. Well, I hadn't noticed that paper and this paper, because those authors have done a really up-to-date literature review and so on. So that's a first reason I encourage younger trainees to, if they have an opportunity, if they're sent a paper for review or invited on a review board, get involved. And the second reason is it is a pathway to becoming a senior editor in a journal like this, because if you enjoy peer review, it's professionally enjoyable. You get to network with really good people who work in these journals, and then ultimately, before too long, you can find yourself on the editorial board and on the senior editorial board. Have you any words of encouragement for our audience and younger trainees about why it's a good thing to get involved in peer review and in the journal industry?
Well, it's an altruistic thing as well, right? So if you send in the manuscript yourself, being an author, you would like to have it reviewed properly, and you would like to get feedback that's appropriate for the manuscript you submitted, and you want to learn from the feedback, and you want to improve your manuscript. So others invest time in improving your manuscript. I think then it's an altruistic thing to contribute, to the community. I know it's controversial because we are all contributing also to the income of the publisher, and that's a whole different discussion. It's a very, very, very difficult discussion, but I think it's giving something back to the community and learning as well, as you said. And that has been particularly rewarding as an editor as well. You do know firsthand and before everybody else what's going on in your field, what research is being done, what groups are doing what research. And that's very helpful and very, very insightful.
That's terrific. Thanks so much, Maarten. Now, I can't finish without asking you a question about something I think you said to me one night late in a pub in Bratislava a few years ago when we were at the AAEU and we were chatting about hobbies and interests. And my recollection coming away from it was that you're a keen biker, that you're a motorbiker. And I have this vision in my mind of you, with a big, fancy, powerful motorbike touring around Europe during the summer with all your leathers on. But was I right about that? Mm-hmm. Is that one of your interests away from urology?
Well, the first thing you're right about is that I probably say too many things in pubs in nights, especially combined with urology events. You're not completely right. You do recollect correctly that I was occupied with motorbikes, but I would never ride one. So I don't have a driver's license. In my first 3 years of training, I did general surgery first with a lot of traumatology, and I saw the effects of motorbike riding. I would never do that, especially not when I have kids. But I do like the technique, so I do restoration and nut and bolt, like completely tear a motorcycle apart and rebuild it. So I like working with my hands. Also, DIY, is it in English, I think? We're constructing a house, try to do much myself. And yeah, I like to work with my hands also outside of the job.
How fantastic. So I was a bit mistaken in my collection. So you actually restore like real motorbikes. So you'll take a classic motorbike and do the work on the engine and the...
Yeah, I try to at least.
Well, maybe for viewers on YouTube, I might convince Maarten to send us an example of a motorbike, and we'll post it up here at the end of this segment. So, Maarten Albersen, Associate Editor at European Urology and Urologist in University of Leuven. Thanks very much for joining us on the European Urology Podcast.
Thanks for the invitation again.
So that's all we have time for on the November edition of the European Urology Podcast. Thanks very much to our fantastic guests for contributing to the podcast today. I must say I really enjoyed the mixture of papers that we had on today and the really lively discussion. So thanks to everybody for joining us. Handing over to you, Joyce.
Yes, I really enjoyed this already. Third podcast. Only one left, Declan, for this year, and then it's 2024. Time is really going fast. So make sure to subscribe to our channel, listen to our podcast. And again, if you have comments, if you have any suggestions, please let us know. We will take this into account. And very much looking forward to our next session, Declan.
Thank you. Take care.